Amniotic fluid disease and abnormalities during pregnancy. First, remember the physiology of amniotic fluid, and then to enumerate the functions of the amniotic fluid and understand causes and complication and management of some diseases occurring with amniotic fluid like Polyhedrams and Oligohydramnus. Amniotic fluid actually is that fluid contained inside the amniotic sac and surrounds the fetus. How is amniotic fluid formed? The normal amount of amniotic fluid at full term ranges from 1 to 1.5 liter or 1,500 cubic milliliter. It starts at 20 weeks to be about 400 milliliter and increases gradually till it reaches its maximum at 32 weeks, and then from 36-37 weeks it decreases. At 40 weeks or full term it is about 800 cubic milliliter. Don't forget the range from 1 to 1.5 liter. It is a clear, pale yellow or opaque fluid at full term. It is formed before 20 weeks by diffusion from the maternal plasma and diffusion from fetal skin. Once the fetal kidney is formed in the second trimester and start to function, the fetal urination becomes the major source of amniotic fluid, followed by amniotic epithelium secretion and other fetal secretions as from lung, salivary, and sebaceous glands. These main sources occurring usually after 20 weeks, and the maternal source present after 20 weeks is still transudation of a small amount through the placental surface. Again, the amniotic fluid is that part contained inside the amniotic fluid surrounding the fetus. It is ranges from 1.5 liter. This fluid is formed earlier before 20 weeks by maternal transudation from the maternal plasma and the fetal skin, and after 20 weeks formed mainly by the fetus, and the main source of amniotic fluid after this gestational age is urination of the fetus or fetal kidney. So by logic, if there is fetal abnormality or anomaly or renal troubles, it actually affects the amount and subsequently functions of amniotic fluid. The amniotic fluid contains about 99% water, and the other 1% is organic substances like urea, enzymes, hormones, and non-organic like sodium, potassium, magnesium. And at the end of gestation, it contains some skin cells and secretions like vernix caseosa, lanugo hair, and the squamated epithelium from the respiratory or gastrointestinal tract. This content at the end of pregnancy is important as it can be used as fetal maturity and fetal well-being test. Regulation of the volume of amniotic fluid is occurring by the balance between the secreted amount of amniotic fluid and the consumed amount. Again, the secreted amount mainly from the fetal urine and transudation from the placenta, from fetal skin, from amniotic membrane, and so on. But the consumption occurs by swallowing of the fetus, inspiring of amount of amniotic fluid inside the gastrointestinal tract or inside the respiratory tract. Physiology of the amniotic fluid. What is the function of this amniotic fluid? The main functions of amniotic fluid is for the fetus, as during pregnancy it protects the fetus from external trauma. It has nutritive function as it contains organic and non-organic substance as we mentioned. It has a developmental function for the respiratory tract and the breathing movement by imbibing fluid inside the alveoli. It helps fetal movement, limb, upper or lower or total body movement, and this helps muscular development. And it is a medium for fetal excretion of waste product, and as it contains some antibodies coming from the mother, it has immunological function for the baby. During labor, The cervix is dilated first by the bag of water, so it helps for cervical dilatation and also avoid cord compression against the presenting part. When the membrane rupture, this fluid is sterile and it has a washing effect on the genital tract during birth. This is the fetus inside. The blue area is the representative for amniotic fluid. Okay? Disorders of amniotic fluid include polyhydramnios, oligohydramnios, premature rupture of membrane or pre-labor rupture of membrane, chorioamnionitis. But here we'll discuss polyhydramnios and oligohydramnios. Now, what is the definition of polyhydramnios? It is excessive accumulation of large amount of amniotic fluid as it equals more than 2000 cubic millimeter, or to the extent that it interferes with easy palpation of the fetal parts or auscultation of fetal sound. Please remember the normal amount 1 up to 1.5 liter. It is least at 20 weeks and decreases again at 37 weeks as it reaches about 800 cubic millimeter at full term. Again, another definition by ultrasound, it is amniotic fluid index more than 25 centimeter. If you remember, we mentioned amniotic fluid index in biophysical profile. Here is the uterus and the fetus dividing the amniotic cavity inside the uterus into 4 quadrants, 1, 2, 3, 4. We take the deepest vertical pocket inside each one, and the summation of 4 pockets equals the amniotic fluid index. It normally ranges from 8 up to 15. Less than 5 centimeter by summation equals oligohydramnios. More than 20 by some is considered as polyhydramnios, but others consider more than 25 centimeter as polyhydramnios. Again, another definition for polyhydramnios, it is that term given to an excess amount of amniotic fluid more than 95 tensile for gestation on ultrasound. Again, amniotic fluid index more than 25 centimeter, amniotic fluid amount more than 2000 cubic millimeter. The incidence of polyhydramnios about 1% in all pregnancies. Other causes. Looking into physiology, the fetus is the main source of amniotic fluid. So, fetal causes are commoner than maternal causes, rapidly accumulating and occurring earlier in pregnancy and associated with bad obstetric outcome. So, fetal causes of polyhydramnios are usually called acute polyhydramnios. Maternal causes of polyhydramnios are less occurring and occurring usually late in pregnancy after 20 weeks, 24 weeks, and gradually accumulating and easily treated and could continue pregnancy, so named chronic polyhydramnios. Maternal causes like diabetes or large-sized placenta as placental chorioangioma, arteriovenous fistula or shunt at the level of the placenta, associated infection like syphilis, as it may lead to edema of the placenta or fetal liver cirrhosis, severe general edema in the mother like cardiac edema, hepatic edema, renal edema, or angioneuritic edema associated with edema of the placenta and more transudation. Increased maternal serum prolactin may increase osmotic pressure towards the amniotic fluid with more transudation from the placental side. Looking into the fetus, multiple pregnancy, especially monoclonic twin, is considered as the commonest fetal cause. Esophageal atresia or tracheoesophageal fistula. In this state, there is, bad swallowing. Duodenal atresia with decreased swallowing again leads to accumulation of more and more amniotic fluid inside the amniotic sac. Central nervous system anomaly like anencephaly or neuromuscular fetal abnormality preventing swallowing, or congenital fetal heart failure, or increased placental mass due to fetal cause like those with hydropsy fetalis, RH isogonization, fetus with severe anemia, or cytomegalovirus infection. All of these leads to edema of the placenta and more transudation, or associated liver cirrhosis in the fetus and liver cell failure reflected by, again, fetal edema and the edema of the placenta. In most of cases, the actual cause of polyhydramnios is unknown, so it is named idiopathic. Again, fetal causes more than maternal. Fetal causes are usually called acute polyhydramnios, maternal called chronic polyhydramnios, but the commonest cause is idiopathic. How can we diagnose polyhydramnios? Clinically, the mother complaining of excessive pressure symptoms due to rapid accumulation of fluid inside the uterus and rapid abdominal enlargement. So, these pressure symptoms may present by dyspnea, epigastric pain, frequent micturition, defecation, edema of the lower limb, or swallowing at the abdominal wall and vulva. Now, what are signs detected by general abdominal or local examination? By general examination, there may be dyspnea, restlessness of the mother, anxious mother, and cyanosis at some time. By abdominal examination, due to over-distension of the abdomen, there may be glistening skin and dilated veins all over the abdomen. The size of the uterus by fundal level is more than the duration of amenorrhea or gestational age. Undoing fundal grip, umbilical grip, first pelvic grip, there is difficult to palpate the fetal part. And usually, due to easy movement of the fetus, there is malpresentation and malposition. On auscultation of the fetal ultrasound, it is difficult as the fetus gets away inside the water in the amniotic fluid. Vaginal examination usually not done, but on BV examination, putting your hand on the anterior fornix or lateral fornices, there are boogie dilated fornices from pressure inside the uterus due to accumulated fluid. In chronic type, the symptoms and signs are slowly progressive, so tolerable by the mother. The main investigation is ultrasound. If you remember, we will do amniotic fluid index. If one pocket of our 4 vertical pockets equals more than 8 cm, it is diagnostic of polyhydramnios without measuring the others. Okay? What are differential diagnosis of a case of polyhydramnios? Simply, all causes of oversized uterus more than the duration of pregnancy. Like, yes, twin pregnancy, associated fibroid with pregnancy, miscalculation, macrosomic baby, yes, or associated ascites pregnancy, or ovarian tumor associating pregnancy, being the ovary is in combination with the uterus, it may lead to mistake as oversized uterus. Here is again the fetus inside the uterus, the bluish area representing the amniotic fluid. A large pocket more than 8 cm equals polyhydramnios. Even one pocket more than 8 cm equals polyhydramnios. No need for estimation of the other 3 pockets. Yes, the management of polyhydramnios actually is directed towards the cause. But acute polyhydramnios is commonly associated with fetal abnormalities or anomaly, and termination of pregnancy is better. If termination of pregnancy decided by vaginal delivery, we will do artificial rupture of membrane to stimulate uterine contraction, and will give the patient ecobolics like oxytocin or prostaglandin. Or we can terminate pregnancy by cesarean section when indicated, like patient with previous cesarean section, macrosomic baby, or multiple anomalies. In chronic type, usually we try to conserve pregnancy till maturity of the baby, and the first line of treatment here in chronic state is treatment of the cause, as correction of diabetic state of the mother, correction of cardiac patient, correction of hepatic patient, renal patient, and so. And if dyspnea will appear, ask the patient to rest in bed in semi-sitting position, give her sedative for good sleep, and we can do frequent amniocentesis or amniodrainage. Yes, to decrease amount of amniotic fluid by aspiration. And you can give the mother some drugs to decrease amniotic fluid formation by affecting fetal urine formation, as indomethacin or prostaglandin synthase inhibitor, as if you remember, prostaglandin leads to renal artery dilatation and increase the blood supply of the kidney with subsequent increase in GFR and urine formation. Now, indomethacin inhibits this action of prostaglandin and decreases the amount of blood supply passing to the kidney and subsequently decrease amount of urine formation. When this fetus reaches maturity, active termination either by artificial rupture of membrane for vaginal delivery and pitocin drip or by cesarean section when indicated. After discussing definition, incidence, etiology, diagnosis, and treatment of polyhydramnios, what are expected complications of polyhydramnios during pregnancy or labor? Actually, complications occurring for the mother are more than those expected for the fetus. For the fetus, there may be prematurity complication if delivered earlier, and during delivery, there may be cord prolapse after rupture of membrane due to wide space, sudden pushing of the fluid down, and presence of malpresentation and non-engagement. This regarding the fetus complication. Regarding a maternal complication occurring during pregnancy, there may be abortion, liability for pressure symptoms, as we mentioned in diagnosis, malpresentation, malposition, non-engagement, and liability for preterm labor. Malpresentation and malposition and non-engagement usually are associated with increased risk for instrumental delivery and cesarean section. So, during labor, if we are deciding for vaginal delivery, there may be prolonged labor from over distension of the uterus and exhausted uterine muscle, leading to what's called uterine inertia. Associated early rupture of membrane, another complication for the mother with more liability for infection. Sudden gush of fluid down can lead to sudden drop of the pressure inside the uterus and accidental hemorrhage, and may be associated with shock of the mother. All of this can lead to more liability again of instrumental delivery or cesarean section. Instrumental delivery, cesarean section, atony of the uterus, yes, can give the mother risk for atonic or traumatic postpartum hemorrhage with more liability for shock, peripheral sepsis, and subinvolution. To remember, polyhydramnios is excessive accumulation of large amount of amniotic fluid, more than 2 liters, or to the extent that difficult palpation of the fetal parts or auscultation of fetal heart sound, or amniotic fluid index more than 25 cm or more than 95th of centile of amniotic fluid level for the corresponding gestational age. Regarding etiology, fetal more than maternal, but the commonest cause is idiopathic. Regarding diagnosis by symptoms, there may be acute or chronic polyhydramnios, acute occurring usually earlier at 20 weeks or earlier due to fetal anomaly, and the mother complains of rapid abdominal enlargement, pressure symptoms, edema of the lower limb, and dyspnea. On examination, there may be dyspnea or cyanosis, fundal level more than the expected duration of pregnancy, dilated veins on the skin of the abdomen, and difficult palpation of the fetal parts, and difficult auscultation of fetal heart sound, and bougiephoresis on local examination. By ultrasound, amniotic fluid index more than 25 cm or one pocket more than 8 cm. Yes, regarding treatment, in cases of acute polyhydramnios, termination is a must. In cases of chronic polyhydramnios, correction of the cause like diabetes or anemia or maternal cardiac state or liver state or renal state and so on, and bed rest, and give hypnotics to help sleep of the mother, and give mother drugs to decrease fetal urine formation like prostaglandin synthase inhibitor. On deciding termination of pregnancy, vaginal delivery or cesarean section, but during vaginal delivery, we can do artificial rupture of membrane and give ecobolics like oxytocin or prostaglandin to initiate and stimulate uterine contraction, and guard against atony or trauma or atonic postpartum hemorrhage or traumatic postpartum hemorrhage. What about oligihydramnios? Definition of oligihydramnios it is too little amount of amniotic fluid, or decrease the amniotic fluid index less than 5th centile for gestational age. In other words, the amount of amniotic fluid less than 500 cc or amniotic fluid index less than 5 centimeter. Polyhedrams. There may be again fetal causes, maternal causes, and idiopathic. But fetal causes expected more than maternal and idiopathic causes. Actually, if you remember, the kidney is the main source of amniotic fluid, so renal anomalies are the commonest causes leading to oligohydramnios, like bilateral renal agenesis or complete obstruction of renal tract, or bilateral multicystic kidney with failed fetal kidney, or intrauterine growth restriction with decreased amount of urine formation, or post-maturity or premature rupture of membrane. Okay, rare cause occurring in the mother as cases of preeclamptic toxemia due to vasculopathy present in the placenta and associated vasoconstriction and associated also intrauterine growth restriction. Okay, here causes of oligohydramnios: renal agenesis, multicystic kidney, urinary tract abnormality or obstruction, fetal growth restriction, some maternal drugs like non-steroidal anti-inflammatory or indomethacin. As we mentioned, it affects amount of blood supply passing to the kidney, post-late pregnancy, premature rupture of membrane. The fetus inside the amniotic fluid with very minimal amount of amniotic fluid. It is a real ultrasound with very minimal amount of amniotic fluid. If we compare this pocket by the pocket we see in polyhydramnios, it is quite different. It measures less than 1 centimeter. How can we diagnose oligohydramnios? Clinically, the mother can give history of the cause like preeclampsia, and she can say failure of abdominal enlargement. It is very suspicious for oligohydramnios. Regarding signs, on general examination, nothing characteristic, but on abdominal examination, yes, fundal level less than the duration of amenorrhea. And here there is easy palpation of the fetal parts. You can palpate the fetal part just under the skin. And easy auscultation of fetal heart sound, but fetal distress is common. And due to difficult movement of the fetus, not like polyhydramnios, here it is a difficult movement. There is also malpresentation and non-engagement. Ultrasound is the main investigation also used for diagnosis of oligohydramnios by detection of amniotic fluid index less than 5 cm or one pocket less than 1 cm. The treatment of oligohydramnios and expected complication. Treatment of oligohydramnios during pregnancy by treatment of the cause like preeclampsia if treatable, and the good follow-up of the mother and the baby till delivery. Some may advise to add amniotic fluid inside by giving worm saline. It is named amnio infusion. During the course of labor, cesarean section is preferred to avoid fetal risk and avoid fetal asphyxia by avoiding fetal umbilical cord or head compression. If vaginal delivery is decided, again you should follow up of this fetus by good partogram and electronic fetal monitoring. Expected complications occurring are mostly fetal because absent this amount of amniotic fluid. Please remember functions. Yes, absent this amount of amniotic fluid can lead to pulmonary hypoplasia, limb anomaly, skeletal muscle abnormality and ankylosing of joint due to undevelopment of this muscle or joint and decreased fetal movement, antepartum fetal distress or cord compression or head compression leading to fetal asphyxia or intrauterine fetal death. Intrapartum fetal distress again may lead to intrapartum fetal death, so we can prefer cesarean section, and at a time there may be intrauterine growth restriction. Please remember with me, definition of oligohydramnios: decrease the amount of amniotic fluid less than 500 cc or index by ultrasound less than 5 cm or one pocket less than 1 cm. Its incidence is rare, but the etiology is mainly fetal. Yes, renal abnormalities mainly, and premature rupture of membrane, post-late pregnancy, intrauterine growth restriction, maternal hypertension or preeclampsia may be a cause. Idiopathic cause is rare. How can we diagnose? The mother usually not complaining except if there is a disease, and she may give a history of delayed abdominal enlargement or failure of abdominal enlargement. By general examination, nothing characteristic. By fundal level, it is decreased than the period of amenorrhea, and is palpation of fetal parts, is auscultation of fetal heart sound, and then amniotic fluid index by ultrasound. And treatment either during pregnancy or during labor, and don't forget complications of oligohydramnios all are fetal and rarely maternal. Thank you.